A very warm welcome to all of you online for today's Q Production web call. And we're privileged to have Catherine Dale. You can see Catherine there on the screen. Catherine is passionate about EBCD. She is really wanting to look at how to give patients more an active and influential role in improving and redesigning healthcare that they use. Catherine has led a program of work to improve patients' experiences of cancer services at Guy's Hospital using EBCD, and she also led the original development of the Point of Care Foundation's EBCD toolkit. She has also taught EBCD for the Institute of Healthcare Improvement. So she's got lots of experience, and today we really want to hear from her about her experiences, some of the challenges, some of the success stories, and it also gives us an opportunity to ask her some of our questions as well. So we have an hour today, and because we do have quite a lot that we would like to cover in terms of EBCD, we will be spending around 40 minutes on Catherine's talk, and then the rest of the time we'll dedicate to Q&A, question and answers. We know that some of you have already sent in your questions, so we will be, Catherine will be looking at them and answering them either throughout her talk or towards the end. But in the meantime, in our group chat box, you probably can, the way to access it is if you look at the page, right at the bottom, there's a little bubble. So if you click on that, a group chat box appears, and I've posted a few questions for you to introduce yourselves, because we do have quite a few people on the call today. So if you can tell us who you are and perhaps where are you intending or hoping to apply EBCD. And we'll try to look through that. In the meantime, if you have any questions at all, please do post it on the group chat, and we'll try as much as possible to answer those questions. Okay, so over to you, Catherine.
Thank you so much. Right, I'm going to share my slides, and hopefully that will work. Here we go. Oh. Okay. Just forgive me. There we go. That's my first slide. Hi there. So I'm Catherine Dale, and thank you so much for that introduction, Rosemary. That was very kind. I'm currently the Programme Director for Patient Safety and Experience at the Health Innovation Network. But as Rosemary mentioned, I have been working using experience-based co-design. I think somewhere it said 15 years. I don't think experience-based co-design has existed for quite 15 years, but I've been using it and the principles of it in my work since 2008. So I had the privilege of working with Glenn Robert, who came up with the original approach in 2008, where I was doing a programme of work with cancer patients in Guy's and St Thomas's and King's College Hospital. And I now have learnt so much using this approach. Today I'm going to talk you through the approach itself, and as we've mentioned, telling you some of the hints and tips and things that I've learnt along the way. And then I'm really open to questions. I know that some of the people from the chat box have learned a bit about experience-based co-design or are using it in their own areas. And even if you're not planning an experience-based co-design project, I hope that there are principles here that you'll be able to take wherever you're at in terms of your knowledge about improvement and your work involving patients. We did want to start by talking about Professor Glenn Robert. This is his Twitter profile picture. I did have another picture, but he didn't have a beard, and he has a beard now, so it's quite important that you've got a picture with a beard, I think. Anyway, he and Emeritus Professor Paul Bate that means he's retired. I've learnt this. They came up with experience-based co-design as a methodology. In 2007, they published this book, Bringing User Experience to Healthcare Improvement. And at the time, it was quite a radical departure from the way in which people were doing improvement work. But the picture in the bottom of that slide is much more where we're at now. It's co-everything. People use co-terms all the time. I sometimes get a little bit cynical about people using co-terms when they just mean more than one person or more than one stakeholder being involved. So I just want to say from the start that when I'm talking about co-design in healthcare, I'm talking about partnership between staff and patients. And when I say patients, I mean patients with an asterisk. So it's everybody who is potential recipients of healthcare. So in some contexts, we're talking about service users of mental health services, mothers when it comes to, or women when it comes to maternity services. Also, in some contexts, we do need to think about the care providers, the carers, or the loved ones of people who are experiencing the disease or the treatment, because they are very impacted by the services, and they can be people that we can be designing services with. So, as again, Rosemary mentioned, there's lots more detail on this, and the Point of Care Foundation are the real source for that. The Point of Care Foundation were originally a programme of work out of the King's Fund, and that's when I was working with them in support of the experience-based co-design programme that we were doing at Guy's and St Thomas's and King's. So they had heard about EBCD, and they wanted to add to the evidence of how much of an impact it had on patient experience. So the programme that I was involved with was evaluated and added to the evidence. And at the end of these slides, there's a lot of references to evidence about how this does have an impact on patient care. But we also, as a part of that programme, developed the toolkit on experience-based co-design that was originally on the King's Fund's website and is now on the Point of Care Foundation website, which is free to access, so people around the world have been able to use the toolkit. And also the Point of Care Foundation do run more in-depth courses on this, which I've helped to develop and deliver. So if people are interested, you're only going to get kind of a bit of an overview today, but if you want to get more detailed support on running your own projects, then please do contact the Point of Care Foundation for that. So I also wanted, we are the co-production special interest group, and I'm talking about co-design. So what is the distinction? Now, I don't want to spend my entire 40 minutes getting into technical talk, but I do think that terminology is important. And basically, this is about the continuum of patient influence in healthcare. When we're talking about these terms, that's the context in which we're speaking. And we're moving from passive patients who are done to, which started off pretty much with coercion, just people, the health professionals were the ones with all the expertise, and patients should just be grateful and were done to, moving into more space where people felt it was important to educate people, but still tell them what. So that meant rather than not telling them why things were being done to them, telling them why things were being done to them. And then we've moved into a phase that is more around patient influence and patient voice, where we are having more of a two-way dialogue with people, getting a bit more insight as to where they're coming from. But it still tends to be more towards doing for. So getting some insight in how what patients need, but still the healthcare professionals being the ones with the expertise in how to deliver that. And then where we're looking at with co-design and co-production is much more partnership with patients, doing things with patients where they are active participants in the work. And in improvement, this is relevant as well, because improvement work is going from first of all, not listening to patients at all and just getting on and doing design or improvement. to listening to patients, maybe doing a survey, getting some feedback from people and thinking, okay, we've sussed out what the problems are, and cracking on as healthcare professionals and making the change. And what we're talking about here is getting insight from patients, but then doing the doing with them, doing the designing with patients, keeping them involved in the process throughout, because otherwise we often miss the point, in my experience. And I thought that the quote at the bottom that I found on a very helpful website, which wasn't specifically about healthcare, it was the difference between co-design and co-production are kind of different phases in the improvement activity, where co-design is about the definition of a problem and the definition of a solution, excuse me, and co-production is about the implementation of the proposed solution. So actually they're both phases of improvement work. But I think in healthcare, it's helpful to start with co-design because we do need that involvement of people in understanding what the problems are and also coming up with solutions. Ideally, we also want to involve people in the proposed solutions, but I do think we need to start with co-design, and that's why I'm focusing on that today. So I've been slightly dismissive of a survey. And I think that we can't dismiss surveys entirely. They're an incredibly important core part of healthcare and how we gain feedback from people. But I think we just need to acknowledge their limitations. So this is not the picture of the woman who was surveyed and interviewed by Glenn and Paul, but this is the picture I always have in my head of this woman. She was asked these standard questions that are asked in inpatient surveys. Overall, did you feel you were treated with respect and dignity while you were in hospital? And she answered, yes, always. That's the most affirmative you can get. And overall, how do you rate the care you received? And again, she answered very positively, excellent. But when Glenn and Paul interviewed her, she mentioned, the other thing I didn't raise, and I should have done, because it does annoy me intensely, is the time you have to wait for a bedpan. Elderly people can't wait. If we want a bedpan, it's because we need it now. I just said to one of them, I need a bedpan, please. And it was so long in bringing it out, it was too late. It's a very embarrassing subject, although they don't make anything of it. They just say, oh, well, it can't be helped if you're not well. And I thought, well, if only you'd brought the bedpan, you wouldn't have to strip the bed and I wouldn't be so embarrassed. And it just brings home to me every time that we need to have conversations with people to find out what's really going on and to gain insight into the things that we need to do to really make changes in healthcare. Because the other thing that happens with surveys in my experience, and when I was working in cancer, we dealt with the National Patient Experience Survey. And sometimes as a healthcare professional, you can feel deluged with information about patient feedback, but you don't know where to begin. But when you speak to people and you identify issues that are currently a problem that you can galvanize staff around doing something about, then you can actually take action to make change. And that, in improvement terms, is absolutely essential. So, on reflection of looking at this, this was done in the context of a lot of other analysis that Glenn, Robert and Paul Bate were looking at when they were thinking about improvement work so far in healthcare. And they realised that we'd learned a lot from a number of industries, but we hadn't learned as much from design industries. So we'd learned a lot from manufacturing and other industries that look at processes. So we'd looked at the functionality of the service, and we've come up with approaches like Lean and Six Sigma, which look at waste and the order in which we do things, and all of those, which have been highly influential and really important in healthcare. That was the first area of improvement that I learned when I started doing what was then called service improvement about 15 years ago. And now that I work in patient safety, I can see how much we've learned from the airline industry and other high reliability industries. The patient safety initiatives are about having things that happen consistently time and time again to avoid harm. But what the design industry does is that it looks at both of those things, but it also looks at the aesthetics of experience. What does it feel like to go through these services? And that is comprised of both your physical environment, the kind of space around you and the way you move through places, and also the human environment, the relationships, the way in which people interact. And from that, that's where they came up with experience-based co-design. Excuse me. Because they recognise that those elements of understanding services and healthcare had been lacking in our improvement approaches until that time. So this is the experience-based co-design process. You've got to have a circle. It's a continuous circle. And we start with setting up, and then we move on to engaging staff and gathering experiences, engaging patients and gathering their experiences, a co-design meeting, which is where you bring staff and patients together, smaller co-design teams that do actual task and finish work, a celebration event that really marks how much progress you've made, and then you set up the next cycle of work. So it is continuous improvement. It takes lots of learning from improvement methodology, but some of the approaches to understand experience are different. And obviously this collaboration between patients and staff is where it's fundamentally different to most of the ways in which we do improvement in healthcare. So it's about patients being at the heart of the quality improvement effort, but not forgetting the staff. If anything, putting the staff experience first. Designing experiences, not just systems or processes, but also acknowledging the systems and processes within there. And it's staff and patients participating in partnership with one another. So I thought I'd just talk you through the process. There is like lots more detail on this, but I just want to whiz through it so that you get a bit of an oversight of the whole thing, and then we can get into more detail in the discussion and questions. So setting up is pretty much like any other change project that you may have done. You're going to have loads of questions, you're going to have resistance from people, you're going to have to think about how this fits in other work that's been going on. The fundamental difference between an experience-based co-design project and another type of service improvement project, or quality improvement project as the terminology we usually use these days, is often with quality improvement we have a problem that we want to solve, whereas with experience-based co-design you have to have a slightly earlier discovery phase where you don't fully know what the problems are, because you're having to understand from the insights that staff and patients will bring to you about the experience before you identify what the problems really are. We may have some assumptions about what the issues are, but those may well be challenged when we go on discovering what's going on. So this is where we have to ensure that we're experience-based, because other forms of quality improvement don't look at experience in the same way. And we do that through using qualitative research methods, really, but you don't have to be a researcher to do these. It's primarily interviews, which may take place face-to-face, one-to-one. They can take place over a telephone. They can be in groups. Sometimes that works. And the other main input is observation, which is a hugely powerful tool for understanding experience and noticing things that you otherwise you just don't even notice on a day-to-day basis unless you sit in a place and watch what's going on while people are coming and going in that space. It's really important that you start with staff, because when you're doing activity that focuses on patient experience, if you don't engage staff and if you don't acknowledge the staff's experience in that same interaction, you're going to have actually a much harder time in getting anything done. And the other thing is, this is co-design. and co-production. And the thing about co is it is a partnership. I think sometimes people get a bit twitchy about patient-centeredness, as if patients are going to take over and be in charge and start telling doctors how to do their job, and that it's going to undermine people's professional training and all their expertise. Now, that is really not the plan, and that is not the way in which this is set up. The other thing that people get worried about is that patients will ask for the earth and that we won't be able to deliver that. And again, where co-design really comes in is you're taking everybody in a journey from what's important now, and having a pragmatic discussion at every stage of the way about what is possible to be changed. It's not about patients coming up with a wish list, sending it off to staff, and then staff going, I have no idea how we're going to do that. It's much more collaborative working, joint understanding of the priorities, and real partnership in trying to find the solutions. But starting with staff and understanding staff's real experience of the services, including some of the frustrations they have in delivering care, is really key to engagement and to success of the work. I mentioned observation. These are my lovely classic slides. This is from an ED department. I always say ED department, emergency department, A&E department in Australia. This is the staff's perspective on that reception space. So if you just go and observe something, and if you take some photos, being careful not to take photos of patients if they haven't given their permission, it's amazing what you notice just through that kind of an activity. And the other thing is you bring staff together. This is a picture of me facilitating my first staff workshop. What is really interesting about bringing staff together as a separate group initially is that they may not have met together as a group that often, and they may not have met together as a group to talk about improvement. Now, you might be working in a place where there's loads of meetings about improvement these days, and that's wonderful. But you might also find in your experience work that you're bringing together a different group of people who don't normally talk to each other. Because when you're looking at an experience lens, you're looking much more at a pathway rather than a service. Even in breast cancer, which was the first place that I started doing this work, patients' experience of breast cancer incorporated a lot of experience in the day surgery unit. So we'd done masses of engagement with the breast cancer team, so a lot of the cancer specialists, but we hadn't even thought about the people who work in day surgery, who were a completely different part of the hospital, and we had to bring them into the meetings as well, because their work was also crucial to patients' experience. Right. Then we move on to engaging with patients and gathering their experience. And just to give you the other perspective on that A&E reception, this is the patient point of view. So you can see it was not a great experience for either party. And again, the power of observation, because these people will have experienced that on a daily basis. But it's when you sort of take a step back and notice these things that there's real power, and people go, that doesn't seem right. And one of the things that was observed in one of our breast cancer clinics was that the clinic started at 9 o'clock, but often patients would be there earlier than that because they were very anxious that they were going to be there on time. But actually, the receptionist didn't get there till 9 o'clock. So people were sitting, but you could get into the waiting area. So people were sitting in the dark for a few minutes, waiting for people to arrive, which is not a great experience. I'm sure you'll agree. So again, it's quite interesting, the power of observation to notice things and to bring people's attention to stuff that isn't going to be picked up in a survey, because that isn't really the sort of questions that we ask or the things that people will bring your attention to. Now, I just wanted to stress that you don't have to have, a child can do filming these days. When we started doing experience-based co-design, which was back in the dark ages of 2008, it was much more difficult to do filming. You had to have a video camera, but these days people can do it with their phones, and editing is much more accessible. Now, it isn't absolutely essential to do filming of patients, but it is way more powerful when people do. There is something about having people share their stories and have those stories filmed and pieced together with a number of other people's experiences. Oh, actually, I'm terribly sorry. I shouldn't have said stories. Somebody picked me up on the fact that we shouldn't refer to patients' experiences as stories. They are their narrative, their experiences. Correcting myself. Yeah, but having people share their experiences on film means as well, if they're willing to do so, which obviously there may be some people who are not willing to tell, to be recorded in their experience. We can talk about that more later if you'd like. But when people are, then by filming that, they only have to tell that, share that experience once, and it has been captured. There are some circumstances I've noticed, particularly around patient safety, where we ask people to tell of their experiences over and over again, and I feel that this might not be that good, really. And also the context in which people are sharing their experiences in experience-based co-design is in order to then take action, agree improvement activity, and do something as a result of that. So that's also where it's different. Through the gathering of information about people's experiences, you can identify key touch points. And these are the moments within a person's experience journey that have really stood out for them. These images are related to the very first experience-based co-design project, which was to do with head and neck cancer. And the touch points that were identified were referred to, a couple of them were referred to as the mirror moment. So the moment at which somebody who'd had significant surgery on their face was presented for the first time with a mirror. But the other thing was the PEG tube, which is for those non-clinical listening, which is when people have the tube inserted into their stomach. That means that they will be able to access food through their stomach rather than eating through their mouth. And as a clinic, the surgery on the face and the head and neck is usually highly complex, takes very highly skilled and experienced surgeons. So clinically, that's got massive significance. Whereas the PEG tube is a much more straightforward clinical procedure. But for the patients, the moment at which they were no longer able to eat through their mouths and had to be fed through a tube in their stomach was enormously significant. And that was something that was news to the staff because they hadn't thought of it from that perspective. They were thinking much more from the clinical significance of the different types of surgery. So this is where identifying key moments for patients becomes very influential in understanding experiences. We also use a tool called emotional mapping, which is similar to process mapping, and you use your touch points to state and ask people to say how they felt at each point. And this also provides people with a mechanism for identifying what are the key things that we ought to prioritise when it comes to making improvement. I haven't got time to go into emotional mapping, but that's something I can share with people afterwards if that's of interest. And so those are very much about understanding experience, but the other and absolutely essential part of experience-based co-design, and something that sometimes people focus too much on gathering experience, but they miss the point about co-design, and this is absolutely at the heart of it. We must carry on the work with patients beyond the understanding of what the issues are. So this is where we bring the staff together with the patients. We'd had an event that separates the patients out as a group, and now we bring the staff and the patients together. And we share the insight. So if the patients have been contributed to a film, they'll have watched it as a group amongst the patients, and now you watch it again with the patients and the staff in the same room, and then those people in the room discuss issues together. And then there's a prioritization process, which again is about a collaborative approach to what are the priority areas that the staff have identified, the priority areas that the patients have identified, and which ones shall we pick collectively to work on. And then you ask people to join groups so that those groups consist of both patients and staff to do some improvement activity on those priority areas. And that's the small co-design team meetings. They're sort of task and finish improvement type groups. And they carry out small tests of change or do more design work to identify what changes need to be implemented. Again, that's going back to quality improvement type methodology, but very much this is about collaboration between patients and staff. And you keep track of the improvements that are made as a result of that activity between patients and staff. You can also use lots of really interesting design tools at this stage. So you might want to use prototyping, you might want to go and observe areas collectively as a small group. It's a really interesting and creative event within the process. And then very importantly, and I don't think I'd ever really been introduced to this in service improvement until EBCD, but there's a celebration. Once you've done work and you've made improvements, it's really important to celebrate, bring people back together, recognise the work that has been done, the things that have changed as a result. And also this can be a launch for other work. So you can invite people in other services or other people who may wish to get involved in future activities along, and they'll see the work that has been done initially, and this will boost kind of your enthusiasm for the next set of work. So what has it achieved? So this is quite out of date looking at it now, but basically there was a survey in 2013 that looked at the way in which EBCD had there'd been 59 projects in 6 countries, and at that point there were 27 projects in planning. I don't know how easy it would be these days to track projects. Glenn does have quite good, people tend to get in touch with Glenn about things, but I don't know that he's quite tracking things in the same way. It has continued to grow, it has continued to spread, but it is still not the default methodology when it comes to improvement. It's still not completely core in everything we do, but there are a lot of people very interested, and it's continuing to grow. And as was mentioned, I think before we properly started, there's quite a lot of work going on in collaboration between Glenn Robert and the place in Sweden that I can't pronounce, that where there will be a lot coming out of that collaboration that will kind of enhance the interest in this as an approach. And also it's been applied in all sorts of different services. I happen to have done experience in cancer services, and sometimes people go, well, yes, that you can do it in cancer, but anyway, there's experience of doing it in emergency medicine with people with learning difficulties, lots of work in mental health. This is a very adaptable and amendable approach. Lots of work with paediatric services as well. Some people in South Africa did some work with HIV patients, many different applications. And if people want specific insights on what, then again, that can be kind of, people can be linked up. It usually takes people about 6 to 12 months to complete projects that use this approach. I don't know quite how that compares to other quality improvement methodology, but I think it's probably quite similar. And sometimes people underestimate how much resource we put into things like surveys, but the richness of these more qualitative approaches are really enormous, I would say. So just that, and as well as it being a quality improvement and insights about quality improvement, there has been an extensive amount of research into the mechanism, how it works, the impact that it has. And I'll give you at the end a list of published papers on it. But it's really useful that people have looked at what the patients actually do, how they contribute, and what it is that they get out of things as well. So they don't just share their experiences, but they do that. They act as an expert and have experiential knowledge. they also very much help identify priorities. And I think that that is extremely valuable. And there are ways of shortcutting straight to work that helps identify priorities by getting a range of different patients involved, rather than just constantly having a long list of priorities where we're not quite sure where to start. They also help to develop the potential solutions, working alongside staff, and can bring all sorts of skills and insights from their lives outside of being a patient. Plus, they don't necessarily have to be highly educated and do fancy design type jobs to do that. Sometimes people who just have a very different life experience than the usual people working in healthcare design can bring some really great insights. I remember a patient I was working with in cancer, where we were developing a new information and education centre for cancer patients. And we definitely were using the word education a lot. And I noticed that this was probably, when she said something, it made me realise it was probably because most of the people involved were quite educated, because she said, do you know what, some of us didn't like school. And it was just had never struck me how off-putting the word education was to a whole load of people who didn't like school. Obviously I do work with some people who didn't like school, I'm not saying that, but I do think sometimes you can associate education with something really positive, when for some people it can be really off-putting, and just that kind of insight is so valuable. And then the other thing that is really key is how patients and other forms of service users can actually help get the work done. I think you do have to put effort in. I'm not trying to pretend that it doesn't take effort to invite people and help them along the journey of contribution, but actually there's often people really willing to give of their time and their insights and to really make a difference in health services, and that can make have such an impact on all of those people involved, especially when you don't necessarily have masses of resources at hand. The fact that there are people out there who are willing to help with things is an amazing boost. And just to let you into a secret, this is not just a methodology or a tool. It is actually about changing your mindset, because once you get into the idea that patients co-designing services is a good thing, you can't go back. You can't think, you might not be able to do it all the time, but there'll be a bit at the back of your brain going, we should be involving patients in this. Why are we not involving patients in this? How can we involve patients in this? So I'm just kind of warning you, if you do get into this, it does shift your mind about the role of patients in healthcare and how significant and important and how ridiculous it is that we aren't doing this type of activity all the time. There you go, I said it. Yeah, so my next slides are really to provide you with some more information about the evidence base. There's many articles published, and I've got a list, and the book, obviously. There's also lots of these tools on the Point of Care Foundation website. There's kind of a list of evidence there. And this is my kind of closing quote, because co-design makes vulnerable people powerful and powerful people vulnerable. There's a way in which it's about equalising the relationship between healthcare professionals and patients. But the very key distinction between healthcare professionals and patients in healthcare is vulnerability. Patients do start off as more vulnerable when they're accessing healthcare services than staff will usually ever be. But this does try to shift some of that power balance. That is part of what happens, which is why I think sometimes people are cautious about it and a bit trepidatious, but actually that's part of the amazing value that it brings, and the way that it can be transformative in changing things. Thank you. I might just have a pause there, but now I'm happy to take questions.
Yes, thank you so much, Catherine, for your wonderful talk. It's now time for questions. We have about 20 minutes for questions. And we have a question from Ash. And Ash asks, what has been your experience of conducting EBCD with minority patients or patients from a non-English speaking background? So what is the best approach to get maximum participation from these type of patient groups?
I think that's a really excellent question. So experience-based co-design does, it is a relative to surveys. So surveys can, you can kind of access a lot of people if you're doing a successful survey approach. And EBCD is a much more restricted number of people. It's a qualitative approach, so you're more about building relationships with people and having more of an in-depth experience with each of those people. Therefore, it's extremely important to think about diversity and inclusion and making sure that you are targeting the population that you are trying to kind of understand and make changes with. I would quite hold my hands up and say that was not my initial, I wouldn't say that my initial work in this was strong on those aspects, because when I first started doing this, I was just so fraught about how we would engage anyone. It was much easier to think about the people who were easier to influence and easier to recruit or invite to participate in things. These days, I always try to encourage people to really think about that from the start. And actually, if you can incorporate a range of different perspectives as part of your patient group right from the start, you're going to have more authenticity in the ways in which the information from your patient group comes across. It needs to reflect the people that you are serving, but also if you have insights from people who are likely to have a range of different experiences, the richness of the design that you will have as a result of that will be way more powerful. There is something about if you're filming people, then giving people who don't usually have voice and influence, giving them screen time is extremely valuable and powerful. So I think this is an incredibly powerful tool for trying to address those things. Another thing that is useful tips in general about patient involvement is about there's an excellent report if you Google it, which is called Beyond the Usual Suspects by Peter Beresford, who did this on behalf of an organisation called Shaping Our Lives. And I heard him speak, and he talks about making it a doddle. Make it as easy as possible for people to participate. And there may be some groups of people that you need to go out of your way to encourage to participate. So invite and invite and invite. And I also think it's quite helpful to think more in terms of inviting people than recruiting people. If you're doing a kind of formal piece of research, you may need to think about recruitment. But actually, when we're talking about improvement activities, I think invitation, inviting people to participate, telling them what you're wanting them to get involved with and why, making it easy for them to opt out at any stage. All of these things are really key. And then on people with different languages as well, I think you may need to call in help from other services where they're dealing with people with different languages. So there may be people who are going to be able to do translation. If you're having kind of group discussion and group activity, then that could get quite complicated. But it's a bit like when people asked about, it's not the same, but when people asked about how to involve children in EBCD, I realised I had no idea because I'd never done it. But then I thought there are probably people around and about who have done this sort of work, maybe not in this context, but tap into people who have the right skills, even if they haven't got it in that context, and ask for their advice. How would you get people to contribute best, especially if you're wanting to sort of get involved in discussion? I hope that's helpful.
Yeah. We've got another question here from Cicely. So she says, I really like the EBCD approach. However, within maternity, there's enthusiasm for whose shoes as an approach to co-creation. And that is where our providers are currently focused. However, my perception is that EBCD provides a great toolkit for how to go about co-design, co-creation, and whose shoes provides the arena to do it. I think it essentially combines those staff and patient meeting and moves into identify the opportunities for improvement. So are you aware of whose shoes? And if so, where would you see the touch points and how do they complement each other?
Okay. I think probably one of the things that I might be getting this wrong, so apologies if I'm not quite. I think sometimes whose shoes might be more of a big one-off event where you bring everyone together, and that is really, really valuable. I think there's something about some of the elements of experience-based co-design as a process, and it might be about how you do whose shoes. I have to say that the things that I learned that I like about from experience-based co-design, where even if I'm not always doing a full-on EBCD project, but I would apply these principles, are A, thinking about experience, which whose shoes does. B, I think there is sometimes value in separating out at some stage staff and patients, and also having a group of patients. That was the bit that I hadn't really appreciated how valuable that was. I think often when we have patient involvement, sometimes we have one patient in a room of 50 people, which can be challenging. I mean, you may get some really super confident people, some of whom are probably on this call now, who are up for that, but it's quite intimidating. It's quite intimidating for anybody to have their voice heard amongst 50 people. And also sometimes healthcare professionals can say, they're the patient, that is the patient voice. And we know patients are people and have a range of different perspectives. So I honestly feel that groups of people with diverse opinions, a number of different opinions on whatever the challenge is, that's really, really valuable. And then even if you don't take all of those into a meeting with staff, if they can come with a sense of this is more than just me, then that can be really valuable as well. This is also, you can get quite, in this whole field and in other fields, you can get quite picky on this one's better than that one because of blah, blah, blah. And I'm not really getting into that. I really want people to be using whichever approach fits in with their organisation, take the principles that patients have a massive contribution to bring. We need to do what we can to really listen to what's important to them. That's another great campaign. What matters to me. I don't think it's an either or. I think it should be all building on one another. And also, if you've got experience of one, you can apply that when trying to take a different approach. And just to be clear that whilst Glenn is very clear on some elements, like when he reflected on the survey of experience-based co-design, he recognised that people were getting more of a handle on experience-based than co-design. I think actually that might be something you might think about with whose shoes. It might be quite good at gaining insight into experience, but does it move into improvement work that is partnership between patients and staff? Because that's the bit that's relatively unusual and that we probably need to be doing more work on.
Another question from Isabel that's sort of similar, looking at how different people, so she's referring to cancer patients, different cancer patients having different types of experiences,
Yeah.
and they vary depending on the cancer sites. So how does it align with the whole EBCD approach, specifically looking, well, I'm adding to her question, the experience from patients, but actually, more importantly, how do you identify the touch points later on to then get on with the designing, with the co-design?
So it's whatever group of people that you've got, and whatever level you're looking. So there's something about, what are we looking at? What is the experience area that we're looking at? So it might be, say for example, in cancer, you might look at outpatient experience, which is going to be broad across different types of cancer. Or you might be looking, as we did in my original work, at a specific tumour type pathway. I don't like that word. Anyway, whichever group you're looking at, you would gain insight, gather experience through interviews, through observation, and you use basically qualitative methods, but I'm not trying to make them sound really scary and like you have to be a researcher. You just have, no offense, Rosemary, but you just sort of gain insight at a cumulative level, and then things start kind of zooming out. They're kind of like you sort of notice, actually that seems to be a big thing. And then you gather a group of people together and you go, these seem to be the key points or issues or whatever, and you validate. You're constantly validating. That was something that I learned early on in service improvement. You gather some information and then you take it back to a group of people and you go, does this look right? Have we missed anything? Is there something, is any of this wrong? And it's a constant negotiation, and it's not pure science. It isn't that we've absolutely honed in on these are the precise things. This is much more about people saying, this feels like these are really important based on my experience and our collective experience. So it's a negotiation and a validation thing. And what I often use, when I'm teaching emotional mapping, I use the GP, making an appointment at a GP practice or going to an emergency department, an A&E department. And even though we've got a random bunch of people in the room together who will have had experience from many, many different places, there's still something about those experiences that has a commonality, and that as a group you can go, yeah, look, that either the making the appointment or the arrival point or the after information for that group of people, those are the key things. So it is kind of negotiable,
and it's also an iterative process, isn't it? It doesn't end.
That's right.
At that point. So you can go back and revisit some of the other issues again.
Absolutely. Yes, it's quite immediate as well, actually. It's iterative, but it's a bit what feels like the most important thing now to these people, and that we will do something about now. So it is quite, it's quite kind of like, I don't know what the right word is.
You get some kind of immediate benefit from doing that kind of discussion, but it's not the end.
Yes. I do remember somebody quite early on when we had some sort of big steering group meeting, kind of somebody went, it's quite reductive, isn't it? And it was like, yeah, it is actually. And that, to be honest, from an improvement point of view, that was quite helpful. It's you, and if you had a different group of people, they may prioritize something different. And you take it to the staff. So if it's a group of patients that are prioritizing, you then take it to the staff, and the staff have to resonate with them. These things have to resonate at this time, and there has to be energy to kind of take them forward. And I think that that's actually quite helpful, because otherwise we spend too long in the analysis phase and we don't get on to doing something. And this drives us towards action. And I think that's also where it's extremely powerful.
I've got a practical question from Alex, who is working in a mental health space, and asking any tips around filming experiences, which can be quite difficult and sensitive.
Yep. Yeah, we've had quite a lot of experience amongst the people doing EBCD in mental health settings. And if you wanted to be put in touch directly with people who've done a lot of that work, then I would be happy to do that. But basically, in all settings, you're always inviting people and asking them if they would be willing to be filmed. And there are obviously some people in some settings for whom that is going to be a much more intimidating barrier. I think you've got to be careful not to assume people don't want to share their experiences, but at the same time be very respectful and careful that people may agree to do something and then they may later wish to withdraw it. So that's it, you use those sorts of principles like you would with research, where it's consent, and that at any time people can retract their consent for participation in something like that. The alternatives, the practical alternatives, are that you could voice record people if they were willing to contribute in that way, or they could, there are some experiences where there are pre-prepared films of other people talking. Health Talk Online has a number of films on their website which you can use within one of your meetings, and you can watch films of other people talking about an experience. You don't have to do the filming at all. It isn't absolutely essential. It's just, and it works as a kind of trigger for action. The other thing I would definitely say is these days, whilst it's much, much easier to film, there's also much more anxiety about where the film will be shared. So pay a lot of attention and ensure that you are being very, very clear and very careful about where any filming is shared, because these are not films that are made for public consumption. They are made for the consumption of the people involved in the work, in order to lead to improvement. So there is real kind of, you need to be careful about the sharing of the films and gaining appropriate consent.
I've got a question here, similar questions from Hisham and Mahmouda around facilitating joint staff and patient group sessions, and particularly sometimes staff feeling quite challenged by patients and carers, and they can actually become defensive as well. So how do you overcome this?
Yes, I think that there is. So I think the reality is that the event where you can bring patients and staff together, I was quite nervous about that the first time I did that, and I actually realised that it is more emotional for staff than that. I was expecting the patient event, bringing the patients together, to be quite emotional and for people to be quite upset. But in fact, it was when the patients and the staff met one another that there was more emotion. So patients were like familiar with their own stories effectively, whereas staff, some of the ways in which the things came across to the staff was more difficult for them to hear. So I think that making sure that you're well prepared in terms of facilitation, that you understand the issues that are likely to come up through the film, so the facilitator has a good insight into the film, and that it is a safe space for everybody involved, that this is not about putting staff on the spot about things, but it is about creating an atmosphere in which they can hear these things and then be taken on a journey to bring about improvement. So some of this goes right back to setting up the project in the first place, having the right kind of sponsorship and support for the work, recognising that some of the issues that come up might be challenging for staff, and that there's a willingness to take people on a journey through that. But also it's kind of not shying away from some of this stuff being difficult, because the context of healthcare is quite difficult. We aren't usually very comfortable with a level of emotion, but this is about taking people through and productively getting something out of it at the end. So taking that responsibility seriously, and getting support and advice from people who maybe have had a bit of experience. But it's about facilitating a discussion well. It's just in a slightly different context, I would say. You're on mute, Rosemary.
Sorry.
It's all right.
Oh, thank you. We're running out of time. There's still some questions that are unanswered, but I think we do need to stop here. And we've got some links from Jamie and Francis on the chat box, so it would be quite useful if people are interested to just have a look at those. Just want to close by thanking everyone, and especially Catherine, for doing the talk today. It's been really interesting. And what we'll be doing is to post the recording, well, a link to the recording soon after the call, and probably, hopefully also to be able to answer some of the unanswered questions.
Yep.
So I just want to plug the next Zoom call that we have. It will be in September. Professor Sue Walker from Typography Department at University of Reading. She's a graphic and communication designer, and she's been involved in lots of work around how to design information for various audiences. And so she will be our speaker next coming September. More details will be posted in time. We haven't got a date yet, but we'll release that as soon as we know. Also, if you are interested to join in, Matthew has put a link to how you can join our Q Community's co-production SIG. So he's put a link up there. Please do join us. We're open to anybody who is interested in co-production. And yeah, we hope to see you again soon. Thank you very much, everyone.
Thank you.
Thank you.
Bye.
Bye.